Hello everyone, thank you for choosing BNMS YouTube channel. We're sitting here at BNMS Spring Meeting 2025 in Glasgow, and it is my immense pleasure to be sitting here with Professor Sally Barrington, who gave our plenary lecture here on her immense experience and knowledge and impact on how we all image lymphoma. So thank you for being here, Sally. We have imposed on you a lot, have we not?
No, it's a pleasure to be here, Simon. Really
Great.
a pleasure to be here, and a great venue here in Glasgow.
And you're transferring from one stage of life to another, and
Yes.
we hope you're still going to be around and helping us at BNMS and influencing us in the pet community. Do you see that, or will you disappear off to Cyprus and never come back?
So I am retiring, and I'm looking forward to doing a lot of the things that I don't have time to do at the moment because I'm working. I'm sure I'll keep a little bit of a hand in, but maybe not too much.
Yes, good for you. Now, when you taught, lymphoma changes, it's at the heart of all of the PET services that we deliver, probably the commonest PET scan that we all deliver. I think even commoner than lung cancer now, and that wasn't always true, but things are changing. And one of those things is the CAR T therapy and biphasic therapy. Can you, what's your feelings about how they're influencing the imaging?
So, as I'm sure you know, Simon, diffuse large B-cell lymphoma is the most common type of non-Hodgkin lymphoma. And for many years, there's really only been one treatment, which has been CHOP chemotherapy combined with rituximab, or sometimes now obinutuzumab. And that's been the standard for about 10 years. There have been lots and lots of different trials, all trying to improve on that, but nothing has really made an impact until recently. And so we now have, for patients who don't respond to first-line treatment, we have the option of CAR T-cell therapy. And I don't know if you know what that is, but basically what happens is that you take the patient's own T-cells, you introduce an inactivated virus which genetically modifies the cells and enables them to express these CARs, which stands for chimeric antigen receptors, on their surface. Then you get expansion of these T cells, and then when you have sufficient T cells that express these CARs, these CAR Ts, you can reinfuse them into the patient, and then the CARs that are expressed on the surface interact with the tumour cell in order to destroy it. And for about 65% of patients for whom CAR Ts are infused, they will experience a complete metabolic response, and of those, a large number will actually experience cure. The only problem with the CAR T-cell therapy is that it takes about 4 to 6 weeks for this process to happen, and in that time, a lot of patients will progress. So usually patients are given some form of chemotherapy or radiotherapy bridging, but there will unfortunately be a number of patients who are either not fit for CAR T-cell therapy or who just progress too far for it to be effective. And so the other thing that's on the horizon at the moment is these bispecific antibodies. So they're bispecific, they have 2 parts, and one antibody binds with the T cell, the other antibody binds with the tumour cell, bringing them together and enabling the T cell to do its job of destroying the tumour cell. Particularly interesting for imaging because PET imaging seems to predict as effectively as it does with chemotherapy the response to treatment, which is so important. And I also see a increasing role for imaging because I think that these treatments are going to come more into first line.
Yes,
so again, we need early interim PET to tell us which patients aren't going to respond to standard chemotherapy.
Yes. So we're going to have so that imaging adapted therapy, which is at the very heart, what you were instrumental in establishing within R-CHOP kind of chemotherapy, is going to continue into a CAR T therapy era.
Yeah,
It's
I
still
think
going to be
so.
imaging adapted, you think?
I think so. So really all the imaging sort of PET adaptation was done in Hodgkin lymphoma, and that's perhaps reducing a little bit with more effective treatments coming into first-line therapy, such as brentuximab vedotin and AVD, and also nivolumab and AVD, and the big large trials that were done that showed survival advantage for these new treatments didn't use PET-adapted therapy.
Yes, yes, yes.
So I think in Hodgkin lymphoma, maybe the role of PET may reduce, but I definitely see the role of PET increasing in diffuse large B-cell lymphoma.
Which is almost the opposite of where we started.
Yes, I
where
guess so.
PET was utterly essential for
Yes.
Hodgkin's, and we had to push and push to get it central within diffuse large B. And like you say in your lecture, other lymphomas
Yes.
are very well established, and yet we might see with these new therapies where PET-adapted therapy becomes less important. Now, is that partly because these therapies within Hodgkin's lymphoma are just becoming so effective that we're not requiring PET adaptation?
I think that's true. I mean, Hodgkin lymphoma is a disease that is eminently curable, and so it's really hard to do trials.
Yes.
Because obviously, in order to
Yes.
show a very small incremental
Yes.
improvement, you need huge numbers of patients.
Yes, so you're taking a brilliant treatment and trying to make it super brilliant.
Yes.
Yes, which is always hard. It's always hard for us to do that. Absolutely. So you've establishing the IMPI, which is this, and there's lots of IPPIs, isn't there? There's IPPI and FLIPPI and lots of them.
Yes.
And you've now got IMPI. So this is adding really MTV, metabolic tumor volume measurements, to this risk-adapted therapy measurement. Isn't that right?
Yeah, so it's really at the start of therapy then. Currently, the IPPI is used, which is 5 clinical factors, and patients are put into risk groups. What we have done is we looked to see whether metabolic tumor volume was a better predictor than the IPI, and we did this in a large group of 1,200 patients collected by the Petra Consortium, and we showed that MTV was better than the IPPI. And then we looked at the 5 individual factors within the IPPI and said, well, can we add any of these factors to the MTV to improve our ability to predict what will happen to patients? And we came up with the IMPI, which stands for the International Metabolic Prognostic Index. And this is comprised of the metabolic tumor volume, the age, and the stage. And what's really cool about it is that it's a continuous score. It's not binary. You don't say, is the patient age 60 or not? We use age as a continuous variable. So you put in the age of the patient, you put in the metabolic tumor volume of the patient, and you don't say, is it high, low?
Yes.
You put in the actual value. You combine it with a stage. And if you look, there's a very nice tool that you can use on the Petra website, and you can put those 3 factors in and you will come out with a 3-year progression-free survival estimate for an individual patient that you can use in the clinic.
Yep.
And we're really excited about that.
Yes, and that's what we all need. This is partly why we're here. So we want you to see Sally's talk, look at this establishment of the Petra Consortium, start trying to use it. And we all must get better at MTV implementation routinely.
Please, Simon, yes.
And again, Petra can help support us do that in a more consistent way across the country, isn't that right?
Yeah, I mean, am I allowed to mention the benchmarks? We have a quick
of course,
time.
yes.
Okay, so we published in the Journal of Nuclear Medicine recently a benchmark data set, and this is really cool. It's a group of 60 cases. You can use this if you're a PET reader, and you can measure metabolic tumor volume using the SUV4 measurement method. That means including anything in the tumor region that has an SUV4 or greater. And you can check your MTV measurement with whichever software you're using, with the measurements that have been made by 12 experts from 9 different countries. And if you can do that, then you can measure the MTV and you can start to use it in the clinic with our IMPI to provide individual patient prognostic estimates that will be more accurate than the IPI, and your haematologist will love you.
Thank you very much for talking to me, Sally. You will be amazingly missed. When I introduced Sally for her plenary lecture, I said she was a very rare academic who reached right into the heart of what you do every day. And here we are at the very end of a long and illustrious career, and you're still doing it. You are still reaching into our clinical practice, changing it and improving it. So please, when we upload the lecture to the BNMS YouTube website, please go. We'll try and connect this to the lecture. And I suppose, Sally, we wish you nothing but luck.
Thank you very much, Simon. It's been a pleasure. Thank you very much.
Okay,
Bye-bye.
bye everyone. Bye.